Hey everybody, and welcome to our next module. I really enjoy covering this module, and I hope you'll find this coverage focused on alcohol and other drugs thought-provoking, especially as the abuse of illegal drugs, alcohol, and tobacco combined is the cause of more deaths, illness, and disability than any other preventable health condition. Substance abuse and dependence is associated with individual suffering and individual expense, but also costs our society as a whole a huge amount of money in terms of loss of productivity, the cost of treatment, the cost of incarceration, which is really often the outcome that's provided in place of treatment, and other societal costs, such as the costs of caring for a baby in the short and long term that's born addicted to opioids. Let's start with some definitions. A drug is any substance that, when absorbed into the body, somehow alters normal bodily function. Obviously, tons of drugs are created and used for healthful purposes like reducing blood pressure, though any drug comes with the prospect of harmful or distressing side effects. Luckily, the prevalence rates of significant side effects are relatively low. Though, as this drug commercial that's linked shows, lots of drugs come with the potential for really serious and concerning side effects. As we look at more specific categories of drugs, psychoactive drugs are those that affect mood, behavior, and cognition by altering the function of neurons in the brain. Typically, though, when we hear about drugs, most often what's being referenced are recreational drugs. These are chemical substances that affect the central nervous system that are specifically used for their perceived beneficial effects. Though, as this module will address, these recreational drugs often come with a high risk for negative outcomes as well, especially as they're used more frequently or in larger amounts. When we talk about drugs, it's important to consider how drugs work or their mechanism of action. The method of administration can vary, as many are taken orally, while others are injected right into the bloodstream, inhaled through the nostrils, where they are absorbed through the small capillaries that are very close to the brain, absorbed through the skin, or injected underneath the skin, where the drug can be absorbed into the bloodstream over time. The method of administration makes a big difference in terms of how rapid the drug's effects kick in, with drugs injected directly into the bloodstream or inhaled tending to have a more rapid onset of effects because the circulatory system can get them to the brain and throughout the body very quickly, instead of having to wait for the digestive system to break the drug down and then be distributed. To an extent, method of administration also affects how long the effects of the drug last, although that is more primarily affected by the drug's half-life, or how long it takes for the drug to break down by one half. Drugs with a quick half-life have effects that are shorter lasting than drugs that have a longer half-life, because those are present in the body for a shorter time than those that have the longer half-life. The fact that method of administration affects how quickly the drug's effects kick in, and to some extent how long they last, is one of the reasons why people do things like crush up and snort pain medications that are supposed to be ingested orally. Now, for those drugs that have effects on the central nervous system, psychoactive drugs and most recreational drugs, these drugs are able to affect the nervous system because they're able to enter into the brain by crossing the blood-brain barrier. The blood-brain barrier, which relatively few substances can actually cross, is a network of very tightly packed capillaries that separate most of the circulatory system from the brain in order to protect the brain, as there are lots of things that maybe enter the bloodstream that we don't want getting through and affecting the brain directly. It's important to recognize that for those drugs that are able to cross the blood-brain barrier, they can have either an agonistic effect or an antagonistic effect, depending on whether they're blocking or minimizing the effects of a neurotransmitter, or whether they're enhancing or mimicking the effects of a neurotransmitter. as well as which neurotransmitter is being affected. An agonist is a type of substance that either mimics or somehow enhances the effects of a neurotransmitter that already naturally exists in the brain, such as how antidepressant drugs, like selective serotonin reuptake inhibitors, can maximize the brain's ability to use or benefit from serotonin. Many psychedelic drugs also are affecting, at least in part, the serotonergic system. In fact, individuals who are taking an antidepressant and then also use psychedelic drugs have a risk for serotonin syndrome, where there's too much serotonin available in the system, and which can cause high body temperature, agitation, tremor, sweating, and diarrhea, which can be so severe it can become dangerous. This is certainly one of the reasons that we have concerns about people who are taking a large number of different drugs at the same time, as these individuals are sort of like their own walking chemistry experiment, because they're taking far more drugs at the same time than have ever been tested in terms of drug safety. And these drugs may be potentiating or increasing the effects of one another, which could potentially be dangerous. On the other hand, drugs can also act as antagonists where blocking or reducing the ability of a particular neurotransmitter to exert the effect that it normally does in the nervous system. Drugs have to very closely physically resemble a neurotransmitter in order to be an agonist or an antagonist, as they have to be structurally similar enough to fit into and sort of trick the receptors that those neurotransmitters normally fill. Now that we've covered a bit about drugs, let's consider drug-related problems. A substance use disorder is the use of a drug to the extent that it's impairing the user's functioning and or well-being. According to the current diagnostic manual for mental health problems, the DSM-5, for someone to have a substance use disorder, they must have a pathological pattern of behaviors related to the use of a given substance. For example, the individual must use the substance more than intended, or be unable to quit using it, or use it in ways that may be dangerous, or experience withdrawal symptoms if they don't use it for a period of time. The full list of diagnostic criteria is listed here. 2 or more of the symptoms are required to make the diagnosis, with the severity being estimated based on the number present, from mild, moderate to severe. Overall, these individuals have symptoms of impaired control, social impairment, risky use, and pharmacological criteria. I want to say a bit more about the pharmacological criteria. Tolerance essentially means that more and more use of the substance is required to get the same effects. Your body is becoming used to having the substance, and so, at low levels, it's able to counteract the substance in order to maintain a state of equilibrium or homeostasis, even when the drug is present. It's a really complicated sort of chain of events to explain, but essentially the body is able to do things, like release neurotransmitters, to counteract the effects of the drug at the level you're used to having it, because the body wants to stay at its best functioning state. It wants to stay in a state of equilibrium, and so when you introduce a substance into the body that sort of throws off that equilibrium, the body has a cascade of events that take place to counteract it. Over time, your body gets used to having to do that for a substance that's used a lot, so it gets really efficient at being able to counteract that substance. And in fact, it can even sort of do that preemptively for a substance you use a lot. So your body, over time, becomes less affected by using the same amount of the substance, and the user has to use more and more of that given substance to have the same effects physically and psychologically. For many of the same underlying physiological reasons, people also typically can develop withdrawal when they use a substance that has the potential for physiological dependence if used frequently. What this means is that when an individual stops using a substance very quickly, there are unpleasant physical and psychological symptoms that occur, in part because the body was already receiving the chemicals needed to counteract the drug, which is now not present. The withdrawal symptoms that go along with different substances vary. For example, the types of symptoms that someone gets from alcohol withdrawal look very different than the types of symptoms that someone gets if they're having withdrawal symptoms from opioids. Also, for many of the same underlying reasons, individuals are more likely to overdose when they use a drug in an unfamiliar setting. For example, if an individual typically uses heroin at their friend John's house, then going to John's house becomes a trigger for the body to do that whole chain of events to counteract the effects of heroin to maintain homeostasis. However, if someone goes to a gas station they've never been to before and uses heroin, the body likely has not been triggered in this way and has not as quickly or efficiently started this cascade of stabilizing events, meaning the drug is not as effectively counteracted and overdose is more likely. Research shows that drugs have a much stronger effect in a novel context than a context that is typically associated with the use of the drug, which is discussed at this link. Keep in mind that while we hear this term thrown around all the time, there is no such diagnosis as, quote, addiction in the DSM. But the term addiction is commonly used to refer to the condition when the body has to have a drug to avoid physical and psychological withdrawal symptoms. Typically, individuals who meet the criteria for severe substance use disorder or lower levels of the disorder but with tolerance and withdrawal symptoms would be considered addicted to that substance. Substance use disorder is the label for the true diagnosis that captures the state of addiction, which is, again, the condition where someone is relying on the drug to avoid both physical and psychological withdrawal symptoms. Also keep in mind that physical and psychological dependence are two different things. They often overlap with one another, but they are distinct. Physical dependence is when the body of an individual who takes a particular substance regularly has become reliant on having that drug present to function normally at a physical level. So when the drug is taken away, there are a variety of physical symptoms that are very unpleasant that occur. Psychological dependence, on the other hand, is where the individual has essentially become reliant on the substance or drug being present to function emotionally or psychologically. Here, if the drug is taken away, they have a variety of unpleasant psychological effects, like upset mood or having their moods change very rapidly, feeling depressed, feeling anxious, wanting to isolate themselves, that sort of thing. So a person can have a physical dependence without a psychological dependence and vice versa. Okay, let's start to look at some of the specific substances we'll cover in this module. In regard to nicotine use and smoking, recent data suggests that about a fifth of U.S. adults are current smokers, while about a fifth are former smokers. When we look at various individual difference factors that influence who smokes, males smoke at a higher rate than females, while young adults are the age group that smokes the most. Only about 8% of individuals who are 65 or older smoke. While we'd like to believe that there's a trend toward people voluntarily quitting over the lifespan, it's also possible that long-term smokers die prematurely of various illnesses and diseases before reaching age 65. We also know that socioeconomic status plays a big role in terms of smoking. When we use the poverty line as the cutoff, current smokers represent 31% of individuals who fall below the poverty line, and only 20% of those above the poverty line. Interestingly, according to one research study, individuals who fall below the poverty line are often spending as much as a quarter of their income on cigarettes or their source of nicotine. There's also a definite negative correlation between education and smoking. While we know that race or ethnicity also plays a role, it's a little bit harder to accurately capture exactly what that pattern is. Though we know that smoking is particularly high among Native Americans and it's really, really low among Asian Americans. In general, it would probably be said that education and ethnicity or race would be the best predictors of smoking status in United States adults. Smoking in the United States peaked in the 1960s and has declined in all age groups since the mid-1990s, when a lot of anti-smoking campaigns and programs were introduced. However, we know that even now, by their senior year of high school, about 13% of males and about 11% of females are already frequent smokers. All right, now let's touch on alcohol. First of all, I find the history related to alcohol consumption to be very interesting. For example, the Puritans, who were sort of the founders of the American colonies, and thus sort of the people who made America as we know it possible, actually considered alcohol to be a gift from God. Men, women, and children all drank alcohol on a regular basis. Interestingly, it may have been a good thing that they did, because at that point in time, alcohol was actually safer to drink than the water or the milk that was available, given the lack of safety procedures that were available at that time. Of course, our country eventually moved into a period where temperance was seen as the ideal. Alcohol was seen as inherently bad, and the prohibition movement developed where alcohol was made illegal. Of course, we know this was totally ineffective and actually created a huge illegal market for alcohol and had a lot of negative and unintended consequences, even fueling things like organized crime. Currently, about 2/3 of adults in the United States are classified as current drinkers, meaning that they've had at least 12 alcoholic drinks in their lifetime, with at least one of those being in the past year. Current drinkers who drink in moderation is about 30%, binge drinkers make up about 20%, and infrequent drinkers is about 14%. Individuals who used to drink but don't drink anymore is about 14%, and people who've never drank, lifetime abstainers, that's about 20%. Similar to smoking, men drink more than women in terms of moderate drinking, binge drinking, and problematic drinking. Younger adults, 25 to 44-year-olds, are the group that engages in the most regular drinking, though 18 to 24-year-olds have the highest rates of binge drinking. Again, similar to smoking, younger age predicts higher levels of use and problematic use. In contrast to smoking, though, a higher level of education is actually associated with higher alcohol use. And European Americans drink more in terms of regular drinking than other ethnic groups in the United States. Similar to smoking, though, the group that has the most alcohol-related problems are Native Americans. Now let's talk about some of the other categories of psychoactive drugs. One category is hallucinogens or psychedelic drugs, which includes things like marijuana, LSD, or psilocybin mushrooms. The common factor of these drugs is that they tend to alter sensory perception and or induce some degree of visual or auditory hallucinations, though the degree varies significantly. This class of drugs is really interesting to me because there are changing perspectives on them. For example, with marijuana, the most commonly used hallucinogen, potential benefits of use, such as inducing relaxation, well-being, and appetite, are being recognized and used for medical treatment purposes, such as for an individual undergoing chemotherapy or with chronic pain. LSD and psilocybin mushrooms are being studied to help individuals with PTSD and very treatment-resistant depression with some very promising results. One particular drug, iboga, has been under investigation as a treatment for individuals with very severe forms of substance dependence. However, that's not to say that use of these substances is not without any risk. For example, people under the influence of marijuana seem to be at an increased risk for injury, with impaired perception and coordination. Individuals using hallucinogens may be prone to have a bad trip or experience panic if not in a helpful mindset or setting. There's a big controversy about whether this class of drugs can cause any sort of dependence. While some research suggests that even marijuana can produce some withdrawal symptoms, other research seems to counteract those claims. Most people feel marijuana and the other drugs in this category are not the type of drugs that are prone to create physical dependence, but there's more of a debate about whether they can set people up to be psychologically dependent, where they feel the drug is needed for normal psychological functioning. Of course, for some people with certain types of symptoms, other psychiatric drugs are used in the same way to maintain normal psychological functioning and are seen as treatment options rather than a problem. In addition, it doesn't seem that psychological dependence is a common outcome because most people who use these types of drugs do eventually stop using them. And in fact, in some parts of the world, hallucinogens are used very frequently in religious practices or rituals as part of sanctioned or formal religious practices. Another category of drugs are the stimulants, which includes a range of substances from nicotine and caffeine to cocaine and methamphetamine. These all work similarly in that they boost activity in the central nervous system and are widely abused because they have powerful reward effects. These are the types of drugs that are associated with very rapid development of physical and psychological dependence. Opposite to the stimulants are the depressants, which depress the functioning of the central nervous system. These include drugs like alcohol, barbiturates, opiates, and anesthetic drugs, and these are also sometimes called sedatives, tranquilizers, or hypnotics. At low doses, these types of drugs reduce sensory responsiveness and seem to slow down cognitive processes, while at higher doses, these produce things like drowsiness and lethargy. Again, these are the types of drugs that can be very highly addictive and can quickly and powerfully set up physical and psychological dependence, especially for individuals who have a tendency toward anxiety or agitation. Because they depress the functioning of the central nervous system, which of course controls things like the beating of the heart and respiration, these are the types of drugs that are implicated or utilized in many suicides. This depressing effect also makes it difficult to have good executive functioning or to make good decisions, also slows down reaction time, and can have unintended effects on people's safety, which is why we don't want people driving under the influence of alcohol or pain medication. Another couple classes of drugs are the club drugs and the dissociative drugs, which are often used recreationally at parties and raves. Club drugs include things like ecstasy or rohypnol, which is better known as the, quote, date rape drug. These drugs have mild hallucinogenic effects, but they tend to create a strong feeling of euphoria, lowered inhibition, and increased empathy, though it's often associated with impaired memory functioning as well. Again, similar to the hallucinogens, there's been some investigation into how we can utilize these beneficial or potentially therapeutic effects to help people. I'd like you to take a look at this link below, which takes you to a clip about how researchers are investigating whether ecstasy might be able to be used in the treatment of post-traumatic stress disorder to make therapy more effective, specifically because of the types of effects that use tends to elicit. Again, this is not to say that there aren't risks associated with using these types of drugs, as anything that lowers inhibitions and creates memory loss has the potential to be dangerous and can leave one open to being manipulated by others, especially if the drug is given to someone without their knowledge and without their ability to plan for how to use the drug safely. Dissociative drugs, which would include things like ketamine or salvia, tend to induce feelings of being separated from one's body, maybe being numb in their body, and perhaps some temporary amnesia as well. Again, people use these because many individuals find these feelings enjoyable, although again, the risk for things to go badly is certainly present. Drugs from both of these classes, while there's the potential for having euphoria and a pleasant experience, also can cause feelings like depression and anxiety and hold the potential for actually causing brain damage, especially at high doses. The risk for brain damage also seems to be associated with the types of behaviors that use tends to provoke. For example, ecstasy-related brain damage seems to be more associated with extreme behaviors, like dancing for hours and hours and hours in a row without drinking enough water and getting the body temperature up to a dangerous level, than just use itself. So in part, it's the drug, but in part, it's also the behavior that it provokes. The last thing I'm going to mention is that there are all kinds of lab-created synthetic drugs available, especially on the black market or dark underground of the internet, where a substance is designed to have structural or functional similarities to and to mimic the effects of having a drug that's illegal. These drugs, like Flocka and bath salts and N-Balm, tend to affect mood, motivation, and perception, but you never really know what you're getting, as these substances are constantly being changed in their chemical structure to try to stay one step ahead of the law, and are obviously not regulated in any way. In many ways, use of these drugs is voluntarily making oneself a guinea pig. They have been shown to induce very violent and very sort of concerning, strange, difficult to manage behaviors. For example, here's a link from 2016 where a college student stabbed a married couple to death and then gnawed on one of the victims' faces before grunting like an animal as police tried to arrest him while he was under the influence of Flocka. There's been a number of cases where people have killed themselves or others, or have done violent things to animals, or violent things to their own bodies under the influence of these drugs. Of course, there are a number of drugs that have the potential to include chemicals or substances that's not what the consumer necessarily thinks they're getting. For example, cocaine or heroin is often cut with other substances that make the drug less pure in order to increase profit for those who sell the drug at the user's risk. I've heard examples of things being cut with rat poison. Obviously, there are a lot of dangers associated with that, which is actually one of the arguments for perhaps why drugs should be decriminalized and sold legally, so use could be safer. Alright, let's move on to considering why people use tobacco or alcohol or other drugs. Of course, many people use substances of any kind because they enjoy the effects or benefits of use. The behavior of substance use is then functional. So the alcohol or marijuana or Xanax or whatever is serving some sort of function, helping the user feel good or perform better or avoid feeling bad in some way. For an example, an individual who uses Xanax will feel less anxious, while an individual who uses LSD may feel more creative or connected to others. There are obviously benefits of substance use. For example, moderate use of alcohol can lead to a lower risk of cardiovascular mortality like a heart attack, a lower risk for developing type 2 diabetes, and a lower risk for Alzheimer's type dementia, probably in part because it does help calm down the nervous system in a potentially helpful way when used in moderation. Of course, it can be challenging to know whether to recommend someone use a given substance when we understand the risks present, either of the use itself or for dependence. One thing that's really interesting about the use of some of these substances and the idea that use relates to the benefits one experiences is that some drugs are typically very unpleasant to use the first time around. Nicotine use, for example, is often recalled as being a very unpleasant experience initially. Of course, use of other drugs like heroin is more often described as a positive experience that one really wanted to repeat from time one. Even if we agree that use typically continues because the substance is serving some kind of function or is rewarding in some way, There still remains a very important question of why does someone start using in the first place? This may relate to social learning, as people often take up a new behavior because they've been told or led to believe, or they've witnessed for themselves that that behavior is in some way, shape, or form beneficial or enjoyable or helpful for others. This belief may lead to a willingness to try a drug for the first time, and even to keep using it even if the first experience was unpleasant. This social learning may come from being affiliated with a particular social group, like having a family where alcohol use is very frequent, or where everyone uses nicotine. We know, for example, that people who grow up in families where the parents or a sibling smokes are more likely to smoke themselves. This learning could also be from one's peer group. I clearly recall that many of my friends in my 20s smoked and seemed to find so much enjoyment from stepping out of parties or bars to smoke together and chat. Peer pressure doesn't have to be explicit, like someone saying, "Hey, everybody's smoking pot, you should too," but is more often implicit, where there's a social norm that use of a given drug is beneficial and positive in some way. Of course, being part of a social group can influence beliefs about a given substance, but also typically provides access to the substance at hand, assuming that we're not talking about a substance that can be easily and publicly purchased. Another place where people get messages that may impact beliefs and social learning is through the media. For example, advertising of nicotine-related products does influence people to start smoking, especially at that critical adolescent age. Advertisements for different brands of alcohol certainly go far in trying to make the link that use of alcohol is a very positive experience. Individuals may also choose to use a drug, even in the face of knowledge of the risks, because of optimistic bias, where the facts surrounding risk are understood, but the individual believes that he or she will not personally be negatively impacted by those risks. For example, someone might say to themselves, "I know there's a risk of sexual assault from binge drinking, but I know nothing bad will happen to me if I binge drink at this party." One interesting side note about optimistic bias is that many people believe this is a way of trying to avoid the extreme existential anxiety that often arises when we ponder on our own mortality. Recalling the diathesis stress model, social norms can actually, in this context, be seen as a stress factor that activates an underlying diathesis for substance use. Research also supports the idea that there may be factors inherent to individuals or individual differences that may influence who starts using tobacco or alcohol or other drugs, especially when we consider problematic use. For example, teenagers who start smoking seem to be less effective at managing stress and have less perceived social support than others, and low feelings of confidence compared with those who do not start smoking. Genetic models of substance dependence have been proposed for all different types of substances and drugs, but they do share some similarities, and the idea essentially is that most of them view addiction as being sort of a chronic brain disease. They assume that individuals who develop a particular form of substance dependence have inherited a biological vulnerability to physical dependence. Twin studies have shown that identical twins who share 100% of their genetics are more similar in substance-related behaviors than are fraternal twins who only share 50% of their genetic material. We also know that alcohol-related problems tend to cluster in families, with identical twins being more similar in alcohol use than fraternal twins. Research tends to suggest that substance use and problems are most impacted by the genes involved in regulating dopamine, a neurotransmitter that plays a very important role in the reward pathway, or our perception of whether a particular experience is rewarding, pleasant, and reinforcing or not. It's not exactly clear why this is, but it may be because of some kind of dysregulation in the dopamine system, either where the system is less sensitive and so more risky behavior is engaged in to try to activate the system to get the rewards, or where the system is overactive and so responds even more strongly to positive experiences than does a typical brain, leading to more dependence. This is a disease model of addiction, where the source of the problem is attributed to a dysfunction in the individual's genetic or biological makeup. When considered as a diathesis for substance-related problems, we can combine disease models with an appreciation for environmental factors as well. For example, parents with severe alcohol-related problems may not be providing quality attachment experiences. So individuals raised by a parent or parents with severe alcohol use disorder may inherit both a genetic predisposition to alcohol-related problems and a persistent pattern of attachment that is unhealthy, which would be considered a diathesis itself, but which also could make stressful situations that could activate the diatheses more likely to occur. One additional thing I'd like to address is the idea of gateway drugs, especially those of you who took part in the DARE programs in school, which is a program to try to prevent drug use and abuse, and which is, as a side note, totally ineffective and actually seems to increase the frequency of drug use for a substantial number of people who go through it, will certainly be familiar with the idea that there are certain drugs, gateway drugs, which if people use will almost inevitably lead to use of more concerning drugs like cocaine, heroin, or meth. While people who are dependent on one substance are more likely to be dependent on others as well, this does not appear to be because of gateway drugs. For example, about 15% of the U.S. population uses marijuana annually, and this is much higher than the percentage of the population that has dependence issues with other drugs. Newer research indicates that the environment probably has a stronger influence on whether people go on to engage in subsequent drug use, rather than just having used, quote, gateway drugs in and of itself. So once people start using a substance, why do they continue? Especially interesting is the question of why do they continue if they're experiencing negative outcomes. Of course, for some drugs, discontinuing use leads to very unpleasant physical or psychological withdrawal symptoms. Thus, avoidance of withdrawal symptoms is a very common reason for continuing use, even in the face of some pretty terrible outcomes of use. Obviously, the withdrawal from nicotine is very different from the withdrawal from OxyContin, but the principle is the same. The individual clearly understands that the very uncomfortable state he or she is in will end immediately if the substance is just acquired and used again. This just overwhelming desire to not suffer these horrible feelings and sensations can drive even the most ethical people to steal or engage in other behaviors they normally would never consider. Of course, removing withdrawal symptoms is the most basic psychological principle of negative reinforcement, taking away something unpleasant, which increases the behavior. We don't understand why some substances produce very strong dependence while others don't, especially as it doesn't really correlate with how strong or emotional the benefits of use may be. For example, we know that cigarette smokers tend to be very motivated to maintain a very steady supply of nicotine in their blood, while individuals who smoke pot may do so very irregularly, with no particular craving in between uses. People may also continue using a substance because they feel they may experience other non-withdrawal negative consequences if they do so. An individual who quits smoking might fear gaining weight, while another one who considers stopping use of marijuana may fear that pain will become unmanageable and lead to far worse risks and outcomes than are associated with the use itself. An anxious individual may fear that he or she would never be able to have friends or social contact without using alcohol heavily. Of course, some of these fears that lead to continued use are unfounded or could be addressed in a different way that doesn't pose such risk. For example, research suggests that people do gain a very small amount of weight when they quit smoking, but this is primarily because they seem to replace the smoking with eating. There is, of course, a social and environmental impact on continuing drug use as well. For example, higher levels of alcohol use would be predicted at a bar or party than at your parents' house. An individual in a sorority or fraternity typically drinks more than other college students. When one is strongly attached to a particular social group, be it one's family or a group of friends or even coworkers, they're not very likely to break the social norms of those groups. Thus, if one belongs to a group where substance use is common, that individual likely has various factors exerting pressure for continued use. In addition, there's a very powerful influence of habit. Our brain has to work very hard to engage in effortful and conscious processing, and very little when we're on automatic pilot and doing things that have become routine. Thus, once a behavior has become routine or habit, it's easier to continue that behavior than to change it. These are all reasons why relapse after discontinuing substance use can be so common. If one is able to stop using a drug, but returns to interactions with the same friends and spending time in the same places, significantly more effort will be required to avoid use than if one develops new relationships and spends time in new places. Of course, assuming these new relationships are with individuals who don't use that substance. So what might be some reasons that one should consider quitting drug use? For many people, their use of certain drugs is not problematic. It's rare and not causing distress or impairment. Motivation to quit drinking or smoking or using drugs often comes when people realize that their behavior is not very functional for them and has shifted to be more of a punishing experience or to produce more negative consequences than positive ones. It may take a long time or repeated negative experiences for this insight to develop, especially in those cases where the short-term outcomes or consequences are favorable, and it's more the long-term consequences or outcomes that are the punishing ones. Many substances put a very high demand or workload on the body, especially the liver, and especially with more frequent and heavier use. Of course, the specific negative health outcomes vary by substance. Use of marijuana is certainly not the same as use of meth. However, chronic heavy substance users are at a greater risk for a whole host of negative outcomes, from liver failure to heart disease to respiratory disease, dementia, cancer, and death, which may be in part because some drugs can impair the functioning of the immune system or because of exposure to carcinogens in the drug. Drug use can also affect one's appearance, which is demonstrated in these links. Some drugs affect hormones and can lead to impotence or sexual dysfunction over time, while many can lead to harm in a growing fetus while it develops in utero if a pregnant female continues with use. This means that the negative effects of heavy substance use and substance use related disorders are not limited to just one individual and can persist over time, such as if a baby is born drug addicted and must deal with birth defects or learning disabilities or difficulties in executive functioning over an entire lifetime. This can also be seen when one's use affects others in the same environment. For example, non-smokers who are regularly exposed to cigarette smoke in the environment have an increased risk for lung cancer and for cardiovascular disease themselves. For children under age 2 who are exposed to tobacco smoke, they're at an increased risk for a whole variety of negative health outcomes, like sudden infant death syndrome, asthma, lower respiratory tract infections, bronchitis, and pneumonia. While the effects do seem to get slightly less severe when the child passes the age of 2, certainly those effects aren't gone. While the risks that I just went through are direct effects, there are also some risks that are more indirect risks, due primarily to the types of behaviors that the drug use may provoke. For example, drug use may lead to a higher risk of unintentional injuries or aggressive behaviors or impulsive decision making. Of course, the specific effects will vary by drug and usually are dose dependent. And of course, how easy or difficult it may be to discontinue the substance use will also vary by the drug. In some cases, increased knowledge and awareness and the personal experience of having negative health outcomes related to nicotine or alcohol or drug use might be what motivates individuals to make the choice to quit. There are also some things that can be implemented either by the society as a whole or by the individual him or herself, or sort of at the group level, to try to increase the motivation and success in quitting. Interventions can also be targeted to an individual's stage of change, or how aware they are of the problem and how motivated they are to make a change in their behavior. Unfortunately, informational campaigns that are designed to try to get people accurate information are really not very effective. Research has shown that even in childhood and adolescence, many messages about the dangers of substance use have been received, but by the time that teenagers or preteens are 14, they don't pay much attention to the health warnings anymore. As has been referenced already, there are many factors influencing our substance-related behaviors that are not simply logical and based on having accurate information. So programs that try to influence social norms, for example, by providing role models in the peer group who are not using substances, are a little more effective than those providing information alone. Sometimes people do decide to change and are able to do it on their own. This is typically called spontaneous or natural recovery. It may involve things like self-help books or the support of family and friends or clergy members. There's definitely evidence that spontaneous recovery does occur. Lots of people who at one point in life would be considered to have substance-related problems later on don't, without having any professional assistance. Another approach to helping or to modifying people's behavior when they've developed problems are abstinence-focused problems, like Alcoholics Anonymous and Narcotics Anonymous. These programs view addiction as a disease and fully believe in ideas like once an alcoholic, always an alcoholic. Because they have this idea that alcoholism resides within the person and is a disease present for life, they advocate for complete abstinence from substance use. These programs do not involve a mental health professional, but instead are run by peers who have dealt with similar problems. One of the problems with Alcoholics Anonymous and similar problems, though, is that participation is anonymous and they don't allow for research about the effectiveness of the programming. And in fact, some research suggests that Alcoholics Anonymous involvement is not an effective way to treat problematic drinking. However, drug court and court-mandated treatment often require participation in these types of programs. A nearly opposite approach to abstinence-only programs is the harm reduction approach. This is where you're kind of saying, I understand that this person is not going to totally give up this behavior because they're either unmotivated or unable to do so, but we're going to find a way to make it less harmful or less risky or problematic. One example is the idea of controlled drinking, which centers on the idea that just because people have developed alcohol-related problems doesn't mean that they can never drink again. It just means that they need to learn to drink in a more regulated way. Research shows that many people who have alcohol-related problems can become controlled drinkers and learn to drink in moderation. This is also the idea behind something like methadone treatment, where you're using other drugs to sort of take the place of the substance that the individual is dependent on, but which has less risks associated with it. Harm reduction is also the primary basis for needle exchanges. Another option for individuals with substance-related problems is psychotherapy. A therapist can help the patient develop motivation to quit through identification of negative consequences of use and ways that use prevents the patient from living a life in accord with his or her values. A therapist can also help a patient identify triggers for use and thoughts that foster use, and find ways to counter these thoughts and problem solve around triggers to use and barriers to sobriety. A therapist can teach the patient new coping skills for any underlying emotional dysregulation that leads to use, such as anxiety or depression as well. Role-playing might be used to help the patient practice how to say no to offers of use from family and friends, as well as how to utilize social support when needed. Sometimes, and this is only if the potential benefits of such treatment would outweigh the risks, aversion therapy can be used. The idea behind this strategy is to try to make using nicotine or alcohol or other drugs more negative of an experience, to sort of shift the pros and cons balance more towards the negative. For example, patients can engage in supervised rapid smoking, where an individual smokes a very large amount of cigarettes in a small amount of time, much, much more than they normally would, to the point that it produces very uncomfortable physical sensations like nausea and lightheadedness. For individuals who have very severe problems with alcohol, sometimes people will be prescribed antabuse, where they will experience very unpleasant physical consequences, like having chest pains, vomiting, sweating, feeling dizzy, and difficulty breathing if they drink. The idea of this approach is that then individuals will associate smoking or alcohol use with these negative physical outcomes instead of the positive ones they get with normal use, so that a new association is made that will hopefully minimize the individual's desire and behavior of smoking or alcohol use. However, punishment therapies do not work nearly as well as most other therapies. In part, I think because people understand that these negative consequences are not the consequences of normal use. Interestingly, sometimes a similar idea of trying to change the balance of positive to negative outcomes of use is also used in society more broadly, such as by banning smoking in public areas or increasing cigarette taxes. Interestingly, it seems the outcomes of these more punishment-based social policies are actually very favorable overall. We also know that discontinuing some types of drugs can be aided by certain medical interventions. For example, nicotine replacement therapy and prescription of a certain antidepressant medication seem to help individuals quit smoking, while various medications can be helpful in coping with alcohol-related cravings. On the whole, the best outcomes are found when an individual is motivated to quit, has few barriers to quitting, has effective social support, and is provided with multidisciplinary treatment. Of course, one issue that's very common when you're working with someone who has alcohol or other substance-related problems is that relapse is very common and is something that actually should be addressed in treatment even before it has a chance to occur. Alright, that finishes up what I wanted to say about this topic. I'll be back in the next module. I hope you're enjoying the course, and please let me know if you're having any questions or concerns.